Good morning. Hi guys, let's talk about IV fluids. These are our objectives. So we're going to talk about IV, discuss the interventions in IV therapy, identify complications of IV therapy, differentiate between peripheral line, PICC line, and central line, and then explain the purpose of IV medication, IV push, and IV piggyback. So IV therapy is commonly used in a hospital to restore previous loss of body fluids, replace any current loss of body fluids. So you see it be given to patients who maybe are dehydrated or have some sort of fluid volume deficit. And so the goal is basically to maintain the daily fluid requirements as well as occasionally some electrolytes. So like I mentioned, it's also used to restore electrolyte balance. It is also used as a carrier for fluid for medication. So if you need to give antibiotics, it just helps push that medication. There are times that you also have to give it to a patient when the patient is unable to swallow medications, or sometimes if they are just unwilling or they just don't want to take PO medications. Or sometimes if it's a medication that can affect the GI secretions, that can irritate the GI tract, an alternative would be an IV form of that medication. Occasionally, you will see it being used together with some procedures for anesthesia or sedation. And there are medications that are only available in IV form. There are times that you can only give like a specific dose of medication if given IV. I guess more specifically, if you want a medication to be within a certain concentration, it's gonna be more consistent when you give it IV because it doesn't have to go through that first pass effect, right? If you give a medication PO, it has to be metabolized by the liver, and sometimes depending on the liver function, that concentration and your kidney function, but that concentration of medication may be inconsistent, and so if you give that medication IV, you may have a more consistent level of medication in the patient's body. And then in emergency purposes, especially because if you give something through the IV, it doesn't really take that long to start working. And next, another reason could be if we are giving medication that needs to be monitored quite frequently, then we use IV therapy as well. When we're talking about IV therapy, we need to understand what serum osmolality is, because that plays a role in how certain medications or IV fluids work. So what's serum osmolality? Serum osmolality is basically the solute concentration in the serum. How concentrated is that fluid? How much particles is in there? And so the higher the osmolality, it means it has the ability to pull fluid in more than some sort of a fluid that has lower osmolality. So remember, the higher the osmolality, it has greater pulling power of water. Your normal serum osmolality would be, depending on your lab, but this is kind of like a general ballpark where it's at, is at 275 to 295. So that's your normal serum osmolality in blood. Now, we describe IV fluids depending on their concentration or serum osmolality. So when we say that a fluid is isotonic, it means that it has the same osmolality as the serum or blood. When we say hypotonic, it means that its serum osmolality is lower than blood or serum. And lastly, whenever we say that a certain fluid is hypertonic, it means that it has a higher osmolality than serum or blood. So for a normal person, if you add an isotonic solution, right? If you give an isotonic fluid, what happens inside the cell? Well, if it's isotonic, so meaning they have equal concentration to the serum, the solute concentration and the free water concentration are about the same, right? So the water just flows in and out of the cell at an equal rate. So for the most part, both concentrations within the cell and also within the serum, it stays about the same. So the same osmolality as plasma. And again, the extracellular fluid remains the same. And it just kind of flows back and forth within those two compartments. So as you can see here in this image, right, basically the water just goes in and out and it stays quite consistent, right? So it has the same amount within the cell and outside of the cell. What are examples of isotonic solutions? The most common one that you'll see in the clinical setting would be your normal saline, and that's one of the reasons why it's always there. You often see it because most of the time that's what patients need, isotonic solutions. Other examples include Ringer solution. Commonly, what you see also, especially in septic patients, are lactated Ringer. So these are also isotonic solutions. Next, let's talk about the hypotonic solution. As mentioned earlier, hypotonic solution will have lower osmolality than plasma or serum. So just remember that fluid or water is attracted to a higher concentration, a place of higher concentration. So what's going to happen is, right, if you are giving a solution that has less osmolality or is less concentrated. So if you give it to the patient and inside of the cell, right, it has more solute or it's more concentrated, the tendency is water is going to be pulled to wherever there's more concentration. And so fluid is going to go inside the cell. So sometimes it's necessary, right? Depending on what's going on with your patient, but on a normal cell, so if there's really no indication for that type of fluid, it can be quite devastating to the patient, because what happens is as water continues to fill the inside of the cell, right, it can overfill and eventually burst. So we have to be very careful when giving medication. So that's why we have to know our patients and we have to know why we're giving IV fluids. IV fluids are basically considered drugs as well, right? We are giving it to the patient. So just like your other drugs, you need to know why are you giving this? What are the things that you want to keep an eye on to make sure that the patient is not getting an adverse reaction from this? So instances wherein you don't want to give this medication, an example would be a patient that had a recent TVA or stroke, and let's say it's very common after trauma or after stroke, you may see some swelling in the brain, right? So if you give that type of patient too much, right, IV fluid that's hypotonic, what can happen to those brain cells, right? It can cause those brain cells to continue to swell up. And eventually, if we are not very careful, those cells can burst. So remember that. Examples of hypotonic solution includes your D5W. So just be very careful with this one. This is tricky because D5W actually starts as an isotonic solution, but once the D5 or sugar, the dextrose gets metabolized, this actually gets converted within the body and becomes a hypotonic solution. So again, that's why for some people, whenever we're talking about D5W, they're going to tell you that this is isotonic, which is true, right? It starts as isotonic, but it ends up becoming hypotonic. So again, D5W starts as isotonic, but then eventually becomes hypotonic. Other examples include half NS, 1/3 NS, 1/4 NS. So as you can see, right, it's a lower concentration. Next, we're going to talk about hypertonic solution. So again, in a healthy environment, in a normal environment, so let's say if you give this to a person who's, cell, everything is basically normal, and you give this to a patient, what's going to happen inside the cell? So again, remember that fluid likes to follow the area of higher concentration. And so if you give a solution, an outside solution that's higher, that's more concentrated or hypertonic, in order to equalize, that's just what the body does, right? In order to try to equalize the concentration of extracellular and intracellular space, it's gonna try to pull fluid outside, right? So if you give something that's very concentrated, it pulls fluid from the cell to the outside environment. And so that's usually how hypertonic solutions work. And so again, what's the hypertonic solution? This is a solution that has a higher osmolality or concentration compared to plasma or blood. So again, this pulls water from the cells into the vessel. Examples of hypertonic solution includes your D5NS, D5LR, saline solutions that are greater than 9%, dextrose solutions that are greater than 5%. And so you will see that for the most part, this is commonly given to patients who have basically cerebral edema. So with patients who had some sort of head trauma that has a lot of edema in their brain, you will see them receiving occasionally 3% saline, because it allows for us to be able to pull some of that fluid outside of those brain cells to reduce that swelling or edema. The problem is, right, we can actually overdo it. You can pull too much fluid from the cell that it can cause the cell to shrink. So we have to be very careful with that. Here are some common fluids that we use to replace some fluids. So we have your crystalloids, which are either isotonic, hypotonic, or hypertonic solution. And as mentioned earlier, isotonic solution can include your normal saline and lactated ringers. Hypotonic solution will include D5W, half NS, and a quarter NS. Then you have your hypertonic solution, right? A more concentrated solution, which are your D5NS and D5LR. Occasionally, we need to give patients some colloids. So what are colloids? Colloids are basically made of protein or starch, and it doesn't really cross the capillary membrane. And so example of this would be blood products, which includes albumin, and as well as TPN. So colloids are just a mixture of proteins or starch, and they're definitely a lot thicker. If you see albumin, if you've ever seen albumin being given in the clinical setting, it's actually a very thicker consistency fluid that we use. All right, let's talk about total parenteral nutrition, or TPN. So TPN is often given for several reasons, but the most common reason is because the patient is unable to take anything by mouth, and we have to meet their nutritional needs one way or another. So when we say parenteral, right, so total parenteral is basically all of the nutrition goes through the vessels or in an IV form. So for TPN, it has water, proteins, carbs, fats, vitamins, and some elements. And usually this can be personalized depending on the patient's needs. So you will see that in the hospital, they will order it and it will arrive. And so we need to give them enough time. So sometimes you may see an order for TPN, but it takes them a little longer to actually make the product, because oftentimes it is actually personalized to the patient's needs. They will need the patient's set of labs, and they can adjust whatever is in the TPN depending. Let's say if their lab changed in the morning, maybe it needs more carbs, maybe it needs more protein, or the patient is losing weight. So again, depending on the patient's needs, they can make those adjustments. Because it has so much things or particles within the fluid, this is considered a very hypertonic solution. Again, it has so many things in there that's very highly concentrated, and so because of that high concentration, it can be very irritating to the vessels. And so for TPN, this needs to be administered only using a central line. So either a PICC line or a central line catheter, or some sort of portacath. So it needs to be given through a central line. Because again, it can be devastating for the patient because of that very high concentration. Now, you have a lesser concentration parenteral nutrition. Sometimes we call it PPN. So peripheral parenteral nutrition, especially for some reason the patient does not have a central line access, or maybe they're still waiting for a doctor to insert one and they just want to get the nutrition going, then you may see them order PPN, or peripheral parenteral nutrition. All right, when we're giving TPN, make sure we need to check our doctor's orders daily. So this needs to be ordered. Now we have to monitor the infusion rate. You don't want to give it too fast, and at the same time, you don't want to give it too slow, right? Because you want to meet the nutritional needs of the patient. If you are giving TPN, please do not give anything with that line. So don't push, let's say, even if it's something as simple as pantoprazole or Protonix, right? This shouldn't be used to administer other medication. Do not make this as your primary and hang a piggyback. So this should be given on its own. The only thing that you can sort of mix with this would be your lipids. But other than that, you don't mix any other medication with this. When a patient is on TPN, make sure that we're weighing them daily, right? Because we want to monitor if this is actually working. Are we meeting our goals? Or is the patient still losing a lot of weight or maybe gaining too much weight? So we want to monitor for both effectivity of the treatment, at the same time, is there any adverse effect from it? We need to monitor our INO, making sure that whatever goes in comes out, right? Depending on our goals. But for the most part, you want it to be somewhat equal, because again, if you see the bag, it's actually a very big bag. And so if you're giving that much fluid, it has to come out somehow, right? And if you don't see any output after giving that much fluid, then you have to be concerned. Just remember that because it has so many ingredients, especially it has carbs, there is a potential for microbes to grow. And so the requirement is the tubing needs to be changed every 24 hours. In addition, you are also required to use a filter with the tubing of your TPN. And because it has carbohydrates, right, we need to monitor the patient's blood glucose. Since we're giving it through the IV, remember, kind of like medications, right, other medications, we are not going through the liver, which metabolizes things. So you get a higher concentration of sugar. So the patient's sugar can spike. And so it is very important to monitor the patient's blood sugar quite frequently. So Q4 hours or Q6 hours, depending on the policy. But those are very common frequency for blood glucose checking. All right, let's talk about vascular access devices, or basically intravenous lines. So there are different types, but mainly you can categorize them between peripheral line or central line. So peripheral line, from the word itself, it's usually put in the periphery, so in the extremities. And these lines are actually quite short. They're really far away from any central vein or vessel. And so this is commonly given to this is commonly seen on patients in the floor. There are times that maybe a patient is a hard stick, or maybe they're requiring long-term IV therapy. Then they may decide to put a central line on the patient. Or there are times also in cases of emergencies, it's usually easier to give the patient's medications through a central line. Maybe they need to give a high volume of fluid, then they may need to put a central line. Now, a common central line seen in the hospital setting, it's actually inserted by a specially trained person, would be your PICC line, so peripherally inserted central line. So the reason for that is because this is actually a very long it has a very long tubing. You may see the insertion site in the arm, so in the peripheries. But actually, that tubing goes all the way to the central circulation in the superior vena cava. Although not a central line, although it's here on the PowerPoint under central line, it is actually not a central line. We also have a line that's somewhere in between a peripheral line and a central line. So we call it a midline. So it is similar to both. The difference is it has a longer tubing or catheter compared to a peripheral line, but it's shorter than a central line. So it doesn't go all the way up up to the central circulation, so it doesn't go all the way to the superior vena cava. Anyway, other central catheters or central lines that you're gonna learn about will be your triple, double lumen, subclavian. So these are types of central lines. You may see some patients with a internal jugular central line. You may have a patient with a femoral line. Other central lines are the Broviac or Grosjean. And you may have some patients, especially patients who need very long-term IV therapy. You may see them with a portacath. Going back on the PICC line, I just wanted to point out that sometimes, depending on what's available in the facility, the PICC line may just have one port, but there are times that the PICC line may have 3 ports or 2. So just keep an eye on that and make sure that you're assessing every port. If it's 3, then make sure you're assessing all 3 and follow the protocols for care of that PICC line. So for peripheral lines, you will have to insert a needle and then introduce a catheter and then remove that needle. Anyway, it comes in different sizes and usually it's color coded depending on the manufacturer, but pretty much here in town it's pretty standard. Same color means usually the same size. So the common ones that you will see in the hospital setting, I rarely see the 16 gauge, but commonly you'll see an 18 gauge, 20 gauge. You will see 22 gauge, and there are facilities that have 25 gauge and 23 gauge. But again, usually what you will see in the regular floors, med-surg floors, you often see 22 and 20. And when choosing the size of the needle, just make sure you keep in mind what's the purpose of this IV. Is it to administer just regular fluids? You're not administering a massive amount of fluid, then you can get away with a 22 gauge. You need to choose the smallest size that you can choose to be able to meet the patient's needs. So what is it? If you're giving blood transfusion, ideally you want a 20 gauge. But you can actually administer blood using a 22 gauge. But ideally, you want a 20 gauge. So again, also look at your patient. I mean, is it really realistic to put a 18 gauge or 20 gauge when their veins are very tiny and they're very sensitive and it can just basically burst quite easily? So again, take those in consideration when choosing the sizes of your peripheral IV. So this is an illustration of the different sites where we can actually insert IVs. I mean, we can really insert it in any vein, but there are some sites that we actually prefer over others. And so cephalic can be used. Just make sure you're going a little farther away from the wrist because it can be uncomfortable and it may be your IV may start beeping too much if it's in the patient's wrist, because every time the patient moves their wrist, it may be occluding that IV infusion. So again, common site. You can also use the superficial dorsal veins, but just be careful because it's more sensitive. But I'd rather use this and maybe a little farther over here than the AC. So AC is on here on the antecubital fossa. So usually when they say AC, they usually use the median cubital vein. And so I'd like to use the basilic vein if possible, a little higher over here, or even the cephalic. But also I'd like to use the forearm a lot because again, this is an area where you don't really bend, so it's easier to access. All right, let's talk about inserting a peripheral IV or PIV. So what do we do? First, we need to gather your supplies, get a start kit, clean gloves, your J-loop. So your J-loop is this one, and then a saline flush. And then you want to get the smallest angiocath appropriate for the patient. So the smallest needle size that's appropriate for your patient and for the purpose of it, right? Know why does the patient need the IV. And then prepare your supplies. So meaning you flush your J-loop, and then, which is this one over here, flush it. Just basically you want to prime it so there's really no air. And leave it there. Keep it aseptic, right? Make sure that things are not touching your surface. And then put some gloves on, place the tourniquet, and then choose your veins. Or should I say, choose the right vein. Once you find a good vein, and really it's not just a matter of visualizing it, because sometimes you can see a vein, but if you're unable to palpate it, whenever you touch it, it kind of like collapses. Most of the time that's likely not a good vein, because then if you try to insert an IV on those type of veins, sometimes they basically just blow on you. So make sure again that you're able to palpate, and be very careful. Make sure that, you know, if there's a better vein, choose that one. Look at the more straight, bigger one, and again, take in consideration the site. Does the patient move a lot? And so is that going to stop the infusion from going whenever that patient is going, is moving? Anyway, so once you chose the perfect site for your IV, you have to disinfect the site. Again, asepsis is the key to prevent potential infection or sepsis. So then after you've cleaned it, please do not touch it again. If you touch it again, then you have to re-clean it again. After it's cleaned, let the alcohol dry a little bit, and then you can insert the cannula or needle in the direction of the blood flow. So as you can see here, right, in that direction, and make sure that the bevel is up. So when I was in nursing school, I've always heard that term, to make sure that the bevel is up, and I never knew what the bevel was. So anyway, I just wanted to include a picture of the bevel. So this is what we're talking about when we say make sure that the bevel is up. So when you're inserting, make sure the tip over here and this opening is up. So this is what a needle looks like. It may look a little different depending on your facility, the manufacturer, whatever supply they have, but it's pretty much very similar if it's not exactly the same. Usually there's a chamber where you can see the blood return, and then there's a button. Sometimes there's no activation button, so you have to push the needle, push the hub instead of activating the button to retract the needle. And once the needle is completely out, it will lock automatically. Again, this is a catheter. The needle is inside the catheter, so the catheter is surrounding the needle. So what ends up staying is your catheter, and when you pull out that needle. So you can see here. So over here on this one right here, it seems like the needle is already out. Over here, they're still trying to introduce it, but you see the blood return over here. This here, it looks like they're just about to poke the patient. Anyway, after you insert it, once you get a flashback or blood return, advance it a little bit more, about 1/8 of an inch. So what you're going to advance there is not the needle anymore. You basically have to push the catheter so that it goes in a little bit. So you push this part right here to kind of thread the needle, to thread the catheter in. And then after doing that, you retract or pull the needle, you release the tourniquet, and then attach your IV tubing or IV extension, depending on what is it that you're trying to do, and then flush it with normal saline, and then close the clamp. And then after that, right, you made sure you flushed it. When you're flushing it, make sure that, it's not leaking everywhere. It's not swelling up, because again, you want to make sure that it's still in the vein, that it didn't move in the process of removing the actual needle, or even in the process of flushing. And so once you make sure that it's in the right place, then you put the sterile transparent dressing, you secure the tubing. If you need extra tape, do so. And also don't forget to date and time it, and assess the site every 2 to 4 hours. It depends. 2 hours is actually quite frequent when it especially in a med-surg floor or med-surg tele. At least every 4 hours, whenever you're assessing the patient, just assess the IV site. Or sometimes, depending on if the patient has really poor veins, then you may need to assess the patient a little bit more frequent than that. So again, it's dependent, but at least every 4 hours is ideal. All right, let's talk about PICC lines. So PICC line stands for peripherally inserted central catheter line. So PICC line for short. So let's talk about how it looks like. So PICC line, sometimes it has one port, sometimes it has multiple port. So it's peripherally inserted, meaning usually it's going to be in the extremities, but it's still a central line, not a peripheral line, because the catheter goes all the way to a central vein. So in this case, it's in the superior vena cava. So that's what a PICC line is. So Usually we use PICC lines for IV therapy greater than 2 weeks. If somebody needs to be on antibiotics and they have to go home with home health services, giving them antibiotics every so often, then they may need a PICC line. Sometimes there are patients who are very hard stick, they have very limited peripheral access, and we have to give them a lot of fluids, or sometimes maybe a variety of medications, and sometimes medications that are not even compatible to each other, so you have to administer them at separate times, or sometimes simultaneously but not on the same port. So you may see that with those kind of patients. And then patients who need TPN, or total parenteral nutrition, and like I mentioned earlier, if the patient needs IV therapy outpatient. And like I mentioned, it ends in the superior vena cava. Sometimes it has multiple ports, sometimes it only has one. Ideally, if you have a patient, or if you're a PICC line nurse or a PICC line person, because sometimes RTs actually start PICC lines as well, so you just have to be certified. But anyway, so if you know they're going to be there, they're going to insert a PICC line, and you know that your patient has so many medications and they may not be compatible, ask them if they can put a PICC line with multiple ports instead of a PICC line that has only one port, because that will really save your day and your patient, they will be able to get all the medications at the scheduled time. So anyway, PICC lines can stay in for months. As mentioned earlier, PICC line can be inserted by specially trained RN or radiologist or respiratory therapist. So there is a hospital, at least one hospital here in town, wherein RTs actually insert PICC lines, which was very interesting. And the only reason why I found out is that, even though I don't work at the hospital, is because my friend is the RT who is certified to insert PICC lines. And I was like, really? I didn't know that. But anyway, so you need to be certified, and not because you're done with nursing school you can insert PICC lines, because I've been a nurse for a long time and I can't insert PICC lines. I mean, I would love to, I just don't have time to train. Well, anyway, so things to consider when choosing the site or choosing to for a patient to have a PICC line. And we need to be the advocate for these patients, right? Because usually the doctor would order it, and maybe they haven't really gotten a chance to really see the patient. So things to consider: if the patient has PICC line in that site, then you can't use it for blood pressure. So what if they have a AV fistula on the other side? Then you have to figure out how else are you going to check your blood pressure. Anyway, in addition to that, if they have a PICC line, make sure you're assessing that at least every shift, maybe every 2 hours, depending on what's the location, what's the status, and what are the things that you're giving. But at least every shift or every time you're assessing your patient, that should be part of your assessment. So not only you're assessing if it's patent, or if you're able to flush it, if it has blood return, but also you want to assess the surrounding site. Also, every time you give medication, you need to assess, make sure that it's in the right place, it hasn't moved. Now, if it looks like it moved, then you need to call the doctor, the provider, and they may need to order an x-ray to check for placement and make sure that it hasn't moved out. Because the last thing you want is that it migrated somewhere else. Sometimes it can actually perforate the vessels, so be very careful with that. And also, like, you don't want to administer the medication when it's no longer in the right place. What if it's more like on a peripheral site, and it's a medication that's very irritating to the vein? So again, assess every time you're giving the medication. Also, you have to change the dressing routinely. Follow your hospital policies. Commonly, central line dressings, including PICC line, they should be changed every week. And together with that, you need to change all the tubings, all the caps, and all those things, as well as the dressings. The dressings together with all the tubings, whenever you do that. Because again, what's the purpose of you changing the dressing when you're going to use the same tubing that you've been using the last week, right? So every time, it doesn't matter. Let's say you just changed the tubing yesterday, and then the following day you are due to change your PICC line dressing, then you have to change everything at the same time. And that just helps prevent sepsis or infection in the bloodstream. Now, after you're done using the PICC line, make sure you're closing the clamps when you are not using it. All right, some complications, like with anything that can be invasive, right? There is a potential for complication. For the most part, if we are following policies and protocols, we're following the guidelines, and we're really assessing things and taking care of it, we're able to prevent most of it. But there are times that you can't really prevent it 100% of the time. So anyway, unfortunately, sometimes patients can develop complications. So complications from PICC line include one, infection, right? You have an easy access to the bloodstream, so that can be a source of infection, and thrombosis. So anytime you have something foreign in your body, really, you can increase your chances of getting a clot. So in addition to that, if the patient is already acutely ill, they're already hypercoagulant at that point, then again, higher risk for thrombosis. Sometimes it can still be occluded, not because of a clot, but for something else. Sometimes maybe medication use. That can do that too. And phlebitis, or inflammation of the vessel. Sometimes it can be basically it can migrate to a different place, so malpositioning of it. And just be very careful, because see, if you see where the location is, right, it's really in the heart, so in the central vessel. And so there are times that if you have a patient who has a PICC line, and let's say everything else is normal, their electrolytes are normal, but then they're having a lot of PVCs, or basically ectopic abnormal heartbeat, and it wasn't there before, you may want to assess your PICC line, because sometimes just the movement of the PICC line from one area, and maybe it's too close to the atria, it can actually irritate the heart, and it can cause some dysrhythmia. So anyway, so malpositioning can cause other things. It can also perforate the vessels, can cause pneumothorax. So again, be very careful. And in addition to that, it can also cause air embolism, right? Because you see all this tubing right here. If we're not very careful, we're not making sure that there are no bubbles in the line, if we're not using our IV, our machines, we may end up causing an air embolism, because look at all this space, right? Can you imagine if air can accumulate here? It goes all the way to your heart and everywhere else, wherever it is that it can go. So again, you can end up with air embolism. All right, next, let's talk about midline access device. So again, as mentioned earlier, midlines are somewhere in between peripheral line and a central line. So the difference is it's a lot longer, and it goes in a bigger vessel than a peripheral line. But unlike the central line, right, the central line goes all the way to the central circulation. Midline doesn't make it there. So as you can see here, right, it just makes it halfway. That's why midway. So just remember that. So it's just midway, and it doesn't go all the way to the central circulation. So that's the difference. So you still can't use it exactly as a central line, but there are medications that you can administer here better than if you had a peripheral line. Anyway, so usually it's about 8 inches. It can stay longer than the peripheral line. So usually you can keep the midline up to 4 weeks, depending on your policy. And it's usually used for antibiotic therapy. And sometimes it can also be because of a patient who is a hard stick. And just remember, because this is not a central line, you can't give TPN through here. So you can't give total parenteral nutrition. And if you have to give some sort of parenteral nutrition, then you use a PPN, or peripheral parenteral nutrition. All right, as mentioned earlier, there are other types of central lines. Usually you don't really see this as often in your medical, surgical, or even tele floors. You usually can see this in, so let's say your IJ triple lumen. So this is a central line. This usually you will see it in the ICU. They usually don't stay long term. This doesn't look like it's a tunneled one. So usually it's used acutely. As you can see here, this has like 3 ports, so that's why we call it a triple lumen central line. And then you have a, this looks like a dialysis catheter. So usually it's located in the right chest. And then you have a peripheral central line. Usually we want to avoid this because of the location. There's a higher risk for infection and sepsis, but sometimes, especially if the patient is very septic, in septic shock, and there's an emergency, the easier to access vessels are going to be the bigger ones, and one of them is basically the femoral site. So for easy access in cases of emergency, and that's usually when you see it. Next, you have tunneled catheters. Usually tunneled, they stay longer, and literally it is tunneled. So unlike the peripheral that starts from the arm, it goes all the way there. They basically make an incision on the chest area and they tunnel it. And there's usually an attachment or a cuff to keep the catheter in place. And you also have a portacath. It is basically a central line wherein it's embedded underneath the skin, and there is a port that you can access whenever you need. And then when it's not being used, you can remove the needle and it's completely hidden, so you don't see the tubing hanging, unlike the other types of central lines. As mentioned earlier, part of the care for patients with central lines is that we have to change their dressing. So dressing change, again, it depends. It's per hospital policy, so make sure you're asking your nurse, you're looking at their policies and procedures. But most often, it's every week. And so, or sometimes even if, let's say, a week hasn't passed yet, but then the dressing is coming off, or the dressing is really dirty or moist, then you may want to change that, right, to prevent infection. So what do you do? How do you do dressing changes? Make sure that you get your equipment, which includes a sterile glove. So this is a sterile procedure, right? Because you don't want to be touching it with your regular gloves or your bare hands, because it can introduce bacteria. Make sure that you're wearing a mask when you are doing the dressing change. Make sure that you have a ChloraPrep to disinfect the area unless they are allergic to it or they get a reaction, but usually that's what you use. And then you have a bio patch. Bio patch, I can't see it over here, maybe it's too small, but a bio patch is actually, it looks like a little disc. It goes around the insertion site, and it's basically a patch that prevents bacteria from growing in that area. And then you also need your transparent dressing and tape to secure the device even better. All right, let's talk about IV infusion. So we use a pump or IV pump in order to safely administer medication. So back in the day, a very long time ago, we didn't use pumps. So it is really hard to gauge how fast you are gonna administer the medication. So back then, depending on the calibration of the tubing, we use drops per minute. We used to really count the drops per minute to figure out the rate, how fast we're administering the medication. But anyway, thanks to technology, we don't really have to use that often anymore. And if not all, most hospitals now use some sort of a version of the Alaris pump that allows you to set guardrails or basically limit. So it warns you whenever the rate is too fast. And sometimes if it's too unsafe, it doesn't even let you start the infusion. The thing with that is you have to really program it appropriately. So always use the pump accordingly, and you need to program it appropriately, because sometimes if you don't follow the policy and you don't program it, let's say you make it as a basic infusion, which you'll learn down the road what it is. But anyway, basic infusion is basically disregarding any sort of guardrails, and you don't specify what medication or fluid it is. So then the machine doesn't know what it is, so it doesn't have limit as to how fast you can administer it. So again, always use your guardrails, always use the pump. So anyway, so it allows you to program the rate, and then in addition, it decreases the rate of air embolism. So these machines are very sensitive. So if there's any air in your tubing, it will start beeping. And sometimes they get too sensitive that even the tiniest amount of air bubbles, it will make that machine beep uncontrollably. All right, so just you need to remember FDA regulations apply when using this machine. Make sure you're using it for its purpose. Don't be creative with it. If it doesn't connect, probably it's not supposed to be there. And also, when the machine is programmed, when you use the machine, make sure that the tubing is primed and obviously connected. This is a different type of an infusion machine or IV pump. I honestly haven't seen that before. Maybe it's for a specialty. If you guys know, please feel free to share with everyone. But I honestly haven't worked with this machine. I used this machine before, and I used the Baxter ones, the really old boxy ones. And then when I first went to nursing school, my first attempt at going to nursing school, we used to count the drips. So that was a long time ago. Well, anyway, let's talk about IV infusion. So how do we set it up? How do we set up a primary infusion? So the main IV. So these terms can be used interchangeably. Primary IV, main IV or continuous IV infusion. So anyway, so let's talk about how do we set it up. So first, we need to set up the tubing. So for tubing setup, and to prepare everything, we need to make sure that we check our order, make sure that it is the right solution, and make sure we're using the right tubing. So if it's a primary infusion, then we need to get the primary tubing. We're gonna see it in the skills lab on IV day, so don't worry, we'll show you. Anyway, so once you're there, you got all your supply. Make sure you're checking your patient's ID. Make sure that you're washing your hands. So hand hygiene, again, it's still very important because, again, sepsis, risk for sepsis, infection, right? You don't want that for your patient. Also, at the very end, and some IV tubings will have ports. They will if they have any sort of caps. So the caps here and the caps here. Make sure it stays in there until you're ready to attach it. So it is easier to keep them clean and aseptic rather than opening it and now you can't really put them down and you are running the risk of touching it against something or touching it with your own hands. So keep this until you're ready to connect it. Anyway, so do not touch the ends. If you remove the caps, it is sterile. So make sure you prime it. So priming meaning you're pushing the air out and filling it with fluids. So when you prime it, you basically spike the bag. So when you open this, make sure this clamp is closed. Open this, connect it to here. So open, pull this. There should be a tab over here that you can pull, and then you can insert this end to this end. And then then slowly open your clamp. So make sure you're filling up the chamber though, because if you don't fill it up, you're running the risk of having a lot of air. And then when you're opening your clamp, make sure you're opening it slowly. The faster you do it, the more bubbles are gonna be in the tubing. So again, the purpose of that is to expel air. Make sure you're attaching it aseptically, and if you touch somewhere when you're not supposed to touch it, then you have to start all over again, get new setup. And then when you're done, make sure that you're charting what you've done. And don't forget to date and time according to your hospital policy, but usually you date and time the IV bags, you date and time your tubings. Next, let's talk about administering IV medication. So we can administer IV push through continuous IV infusion. Sometimes we can also just directly administer it in an IV if there's no infusion going on. But I usually prefer that there's an infusion going because it kind of helps push and move that medication. It also keeps the vein open. Well, anyway, so if you have an IV medication ordered, an IV push ordered, make sure you're checking your MAR, verifying it against the order, make sure they're matching. Again, your 6, now probably we're going to 8 rights of medication administration. So check all your rights, make sure everything, all the information is matching and they're correct. And then also think about compatibility. So is the medication that you're pushing compatible with the fluid or the medication that's going in the tubing in your main IV? So make sure you're checking that. If once you're sure that they're compatible, then you do your hand hygiene and then check your patient ID, your identifiers, name, date of birth. While you're doing all this, make sure you're explaining it to the patient, right? You need to talk to your patient. Inspect the site, make sure that it's still in the good spot. And my recommendation, if you, let's say it's been a long time since you assessed the patient or you just arrived, you haven't done your assessment yet, make sure that before you start pushing any drug in that IV, make sure that you are flushing it and assessing to make sure that it's in the right place. The last thing you want is administer a medication that can be very damaging to the vein or to the surrounding tissue, and it's not even in the vein. So then you can cause more problems. So please assess your site before injecting anything. Anyway, inspect the site, make sure everything looks good, and then select the port that's closest to the patient, right? Because if you choose the farther away, then it's gonna take forever for the medication to go in. And not only that, so if you're only gonna give 1 ml and this from here to here is 1 ml, guess what? The medication is still here. You have to wait for the IV fluid to push it so slowly. So make sure you choose the port that's closest to your patient. Well, anyway, after doing that, prepare the injection site and clean it, and then connect the syringe to the IV line. So this is a needle-less system. Back in the day, so I feel so old. Anyway, back in the day, we used to have ports that we had to poke with needles to access that port, that IV. But now we have this needle-less system, so that I think that's really good. It's safer. Anyway, once you inject it, make sure you follow whatever is the recommended infusion rate, so or how fast you're gonna push the drug. So if in your drug handbook it says push it over a minute, then you need to push it over a minute. Make sure you're watching your watch, you're watching the time. And then same thing when you're flushing the medication, so make sure you flush before, you flush after, right? Flush after you gave that medication if there was no continuous infusion going. So flush after to make sure that everything goes in, and flush it at the same rate that you pushed it. After that, you can discard everything. Obviously, needles go to the sharps, and then everything else, depending on your policy, some may go to the trash, and then if there's some drugs, then it may need to go to the blue bin. Anyway, dispose them accordingly, and then hand hygiene, wash your hands, and then chart in the MAR. And make sure you go back to evaluate the patient for effectiveness, and of course also any possible adverse reactions. All right, as I mentioned earlier, there are times that you don't have any continuous IV fluid going. So what you're gonna do is basically very similar, except you have to flush it. So if you don't have continuous IV, it's saline lock, so meaning it's locked with saline. So it's just cap. And the reason why we call it saline lock is because before you cap it, before you put this cap, you flush it. So every time you do something with IV, you flush it with saline and then you lock it with a cap. So it's saline locked. Anyway, check the MAR, make sure it's matching your orders, and then get your 10 ml syringe of normal saline. Wash your hands. Again, as you're doing this, you're explaining this to the patient, right? Clean the injection port. So the port that you're going to use, clean it with alcohol. And then after that, you basically connect the syringe through the injection port or IV lock, and then aspirate just to check, right? And then pull a little bit, and then flush with at least 2 to 3 ml of normal saline, depending on sometimes you may need to flush more. Also follow policy, because sometimes they may specify how much to flush your IV ports. So again, but generally speaking, 2 to 3 should be enough to assess the site and flush. And then after that, you need to disconnect your normal saline syringe, and then cap it again, cover it with a cap as you're doing everything else. So you're preparing the next thing. And then swab the injection port again with alcohol, and then give the medication. So again, as depending on your drug handbook or your resource, if it says 1 minute, push it in 1 minute, time yourself, and then after that you need to flush it with normal saline, and then you don't slam that, right? You need to flush it at the same rate as your medication. After that, hand hygiene, chart on the MAR, and again, go back and reassess your patient. Depending on what drug it is, then you may need to go there within 30 minutes, maybe an hour, again, depending on your patient and the drug that you gave. All right, next we're going to talk about IV PB or IV piggyback. So IV piggyback, to me, the way I remember it, it is basically kind of like a piggyback. So this IV is riding on the shoulder of this IV bag. So it's piggybacking it, right? So it kind of looks like it if you look at this picture. So anyway, piggyback is basically also known as your secondary infusion. So when do we use IV piggyback? So it's usually in the order IV PV or IV piggyback or secondary IV infusion. And oftentimes what we infuse as a secondary infusion include antibiotics and electrolyte replacement. At times we can administer other types of medications as secondary infusion, but these two are the most common ones. Now, make sure that your main IV, your primary infusion, is compatible with the secondary infusion. So that's the time to use your drug handbook, and sometimes some hospitals will have resources that they use to check for compatibility. Make sure sure they're compatible. And when you are connecting this, you're still maintaining asepsis, so meaning you're keeping everything clean. You're not touching the port, and then you don't connect anything without cleaning it, especially if it doesn't have a green cap. Now, if it has a green cap and you know that, for the most part that it's clean, then you can connect it. But again, maintain asepsis. And after you connect it, you back prime it. So that's the name of the technique. When in order to prime, remember when we prime the primary tubing, we let the fluid flow. For secondary, it is not recommended to do that. Instead of letting the fluid flow, after you connect it, get the secondary bag and lower it. Make sure it's still upright, but just lower it. And it should be lower than your primary tubing, and it will drain to gravity. So fluid from here will start backing up. It will back up all the way here, and it expels the air from this tubing and just goes to the chamber. And now your secondary tubing is now primed. Anyway, so when you're done, when you're ready to administer it, put it back to a higher position to where it's piggybacking off of the primary, right? It should be higher. So secondary should be higher than the primary, so that when the medication is started, the machine will pull that fluid from that secondary bag rather than the primary bag. So make sure you're hanging it higher than the primary bag. Anyway, after you're done, you administered it, right? You check your MAR, make sure it's charted. You do hand hygiene. And then, like with anything else, you go back to your patient to evaluate for side effects and effects. At times, there could be instances where you have air in the IV line. So causes of that, sometimes when you run out of fluids, if you did not set it up correctly, you may run your fluid dry, and then you run out of fluid. So now it's just going to push air in that tubing. Sometimes there may be just fluid trap near the port that can cause some air in the line. So anyway, so what do you do? So the solution for air in the IV line include aspirating from the port. So what I do, at times, if you can disconnect it from your patient, and you find a port and basically pull directly from the port until you're able to aspirate that air. Sometimes you need to push up into the drip, so literally like press on the tubing to press that air and to make it go up the chamber. And sometimes, unfortunately, if there's no other restore, you need to disconnect it and reprime it or get a new setup altogether. But that's the last resort. Usually we try to avoid that because it's really time consuming and it's a waste of resources. All right, let's talk about IV therapy. So these are examples of orders for IV therapy. D5NS at 75 ml an hour. So see how the D5NS is your type of fluid, and then so it will tell you the rate, 75 mLs per hour. There will be instances wherein the doctor or provider will order. Oh my God, I can't talk anymore. I'm tired. Anyway, will order the fluid, so D5LR, and it will tell you the exact amount that you're gonna give. So they'll say give 1 liter over 8 hours. So you're gonna have to set up the pump that way, right? You'll have to figure out the ml per hour rate. Now you can see pantoprazole 40 milligrams IV push daily. So that's a IV push medication. You have this antibiotic vancomycin 1 gram IV piggyback, so IV PB every 12 hours. Then you also have famotidine 20 milligrams IV every 12 hours. Unacin 3 grams IV every 8 hours. So as you can see, there's a variety of ways wherein the provider can order IV therapy. So which do you think are intermittent and which are continuous? So intermittent, you will have the frequency, right? And so intermittent, you will have obviously your 40 milligrams IV push, you just push it once, right? So it's not going in. It's not even a continuous infusion. It's not even an infusion at all, right? Because you just push it. Vancomycin 1 gram IV piggyback every 12 hours. It has a frequency, right? You just do it every 12 hours. So that's intermittent. Famotidine 20 milligrams IV every 12 hours. Again, that's also intermittent. Although sometimes they won't put the P, but usually famotidine and it's usually, unless there's something else going on, usually it's also an IV push. So again, this is intermittent because it's not continuously going. And this unison 3 grams IV every 8 hours, that would also be intermittent. Now your continuous will not really have some sort of a frequency. As you can see here, 75 ml an hour. That's it, right? So this tells you that this is a continuous infusion. So again, no specific order to start the IV. So if you have an order for this medication, as far as what I learned from working at the hospital, is that once a patient gives consent to be admitted to the hospital, part of it is having an IV started if needed. Now this is just for peripheral IVs. Now if they need PICC line and other stuff, the more invasive and bigger types of IVs, the central lines, then they need to have a separate consent. But for regular, like peripheral IV, that's usually part of their admission consent. So you don't have to get an order to start an IV before you start an IV, especially if you have this ordered, right? How else are you going to administer your medication? All right, so once you have a patient that has an IV site, make sure that you are assessing the site. That's part of your assessment. So assess the area every shift, every time you give those medication, and every time you enter the room. There's nothing wrong when you're already there anyway. Every time you're doing a focus assessment, do that, right? Take a look at it, especially those patients who are heart sick and they have a tendency to have their IVs infiltrate. So what are you looking for? So make sure you assess for the location. Where is the IV? Is it in the forearm? Is it in the AC? What type is it? Well, specific one, it would be a peripheral IV. So how's the dressing? Is it dry? Is it intact? So this doesn't look like dry and intact. It looks like it has some drainage. Intact meaning, is there any breakage? Is there any breakage anywhere that's ripped? Redness, tenderness, swelling, warmth, or drainage in the area. Again, look for those things because these are cues that something else may be going on. And sometimes you may see some bruising, especially when you have patients with low platelet, or maybe they're on anticoagulants, or maybe some blood thinners, platelet aggregation inhibitors. Then some of these patients just bruise so easily. So bruising is okay, but all this other stuff, I would be worried. So why is it important to assess the site? Well, one is because of the potential complications. So whenever you have an IV, everyone has really a potential to have an infiltration, right? So what is infiltration? Infiltration is the accumulation of fluid in the tissue surrounding the catheter site. So usually it's caused by the penetration. So the IV or the catheter penetrates the vein wall, and so it can cause an opening or a leak in that area. So what are the signs and symptoms of infiltration? So infiltration is, what signs and symptoms of infiltration include the site is cool to touch, right? And usually it's going to get swollen. It may get hard because of that infusion, or you're continuing to give fluids in that area when it's really leaking around that area. Usually the fluids are going to be cold, so that's why it's going to be cold. And then because of that, the circulation may not be the best, and you have a lot of fluid surrounding that, so it will look pale. It can be painful, especially because of that pressure. You not only have pressure from the fluid, but also you may start seeing some inflammation. And then the IV pump, depends. Sometimes it doesn't, but for the most part, if there's enough pressure, it will cause the IV pump to alarm, basically saying occlusion, depending on what type of pump you have. But it will at times warn you that something else is wrong. As you can see, this patient had an infiltration. Hand is quite puffy. Look at this. And then obviously they removed the IV because once it's infiltrated, you can't continue to use it. So if there's any signs and symptoms of infiltration, please don't continue to use it. That's really torturing your patient. Anyway, so what do you do if the IV infiltrates? You stop the IV infusion immediately, and then you need to remove the catheter, and then make sure that you elevate the extremity. Again, if you look at it, right, that extremity of that patient, of the picture of that patient, it was very swollen. So you want to help with that swelling. You want to make sure that that swelling goes down. Make sure that the patient gets a little bit more comfortable, so it will relieve that swelling, it will relieve that pain. So elevate that extremity, apply warm compress to help with the absorption of fluid. So generally speaking, you apply warm compress. There are specific medications wherein you have to apply cold compress, but generally speaking, you apply warm compress. And then document the findings and actions. Make sure you report it to your provider. I mean, it's not an emergency, but especially, if a patient is heart sick, you may want to report that. But also if there's some sort of drugs that are infusing, then you may want to report that too, so that you can get the appropriate orders if it needs a reversal agent or something like that. Anyway, so if the patient still needs an IV, still receiving some sort of IV therapy, then you may need to restart an IV in a different location. Try to avoid that area because, again, not only it's going to be painful, but also it's going to be really hard to find a vein in an area where it just infiltrates, everything is quite swollen. So your chances of getting an IV in that area is actually pretty low. Anyway, over here there is a link of list of how to manage infiltrations or extravasation depending on the drug. I think this is quite helpful because, like I told you, at times there may be different types of drugs wherein you have to apply warm compress, and not only that, there are medications that need to have a some sort of reversal or agent or antidote to be given in order to reverse or prevent further damage from that infiltration or extravasation. So extravasation, I will talk about it in a little bit. So how do we prevent infiltration? So making sure that the catheter is secure. So if we prevent it from moving around, right, then it will, not likely to infiltrate. Make sure that the extremity is stable. And again, like I told you guys earlier too, you need to choose the appropriate site, because if you put it in a site where it usually bends, the patient usually move their arm, then it has a higher likelihood of getting infiltrated. So again, avoid areas where the flexion occurs. Again, frequent assessment. So assess the IV site every time you're assessing the patient. That's part of your assessment. And make sure that you're keeping the flow rate at the prescribed rate. So don't infuse it too fast, because that can basically damage the integrity of the vessel, and also change the IV site per hospital policy, because it doesn't matter how good of an IV it is. If it's staying there for too long, at one point it will get infiltrated. All right, another complication from having an IV is phlebitis. So from the word itself, right, phleb and itis. Phleb, basically it's the vessel. Itis, it means inflammation. So basically this is inflammation of the vessel. So what happens here? So the inflammation of the vessel will cause pain and discomfort at the site. Sometimes it just happens just because sometimes it's from the tubing itself, or the medication, it may be too irritating to the vein, so it can cause some inflammation in the area. Anyway, so patients would complain about pain or discomfort in the area, and because of the inflammation, there will be inflammation in the lining, so it can cause a sluggish flow rate. It may cause the pump to alarm and saying that it's occluded when it's not. And then there can be some swelling surrounding the area, and there's gonna be redness and warmth along the vein. So that's how you know it's phlebitis versus maybe infiltrate or infection. As you can see here, this is from a mannequin, but this is from a real person. There is some sort of redness or discoloration following that vessel, and if you touch it, it's gonna feel warm. So how do we prevent that? Maintaining asepsis. That would be one of the key to doing that, but at times you can do everything that you can. Some patients are just at a higher risk than others. And how do we treat it? We basically do the same thing that we're gonna do as if the patient had an infiltrate: elevated, warm compress, and so on. All right, thrombophlebitis. So thrombophlebitis is basically a combination of things. So phlebitis, there is inflammation in the vessel, but then thrombo part, there's a clot. So this is when there is a clot and then the vein is inflamed. So treatment is going to be the same as infiltration. This is an example of thrombophlebitis. So what happens is the catheter in the vein has caused some redness and inflammation, and then some blood clot start forming in the area. So usually this is secondary to trauma. So if it's in an area where the patient's always bumping it, then it can lead to thrombophlebitis. So basically inflammation of the vessel and has a clot. Next complication is going to be infection. Again, anytime you have an opening, there is a risk for infection because that's going to be an access for microorganisms. So infection from the bacteria going in the bloodstream via the IV therapy can usually be from the IV site. It can also be from a poor insertion technique if you didn't maintain asepsis, poor maintenance of the IV, poor handling of the tubings, and so on, and sometimes really just the location as well. And so it is very important to maintain asepsis when we're maintaining the IV, when we're inserting it. And really that's why also we want to assess the area. If the dressing looks soiled, then we need to change it. We also need to make sure that we're following policy and protocol and still maintaining asepsis and keeping everything clean when we are manipulating that device. What do we do if there is an infection? We remove the device, we elevate the arm, and we put warm compress to help with the inflammation. Now, there are instances, especially if they think that there was some sort of cause, that IV can be a cause of sepsis or infection in the blood. They may order for the catheter tip, or the tip of the IV to be sent for culture. Although it's not as common with peripheral IV, they can occasionally do that. They can order them to culture it, especially if the patient's starting to have some sort of symptoms of infection and they can't figure out where's the infection coming from. All right, another complication from IV therapy can include circulatory overload or fluid volume overload. Again, this is really, we are giving fluid directly to a patient's vein, and sometimes it may be too fast for the patient or it may be too much. So causes of circulatory overload or fluid volume overload can include infusion of fluids at a rate greater than the patient can tolerate. And again, you can follow the orders as everything to the T, but some patients just can't handle it. And also that's why you also need to know your patient. If the doctor ordered IV fluid at 150 ml an hour and you know that this patient has renal failure and this patient doesn't urinate and doesn't excrete fluids, right, and the patient also has heart failure, do you think they can really tolerate that rate? For the most part, no, they can't. So again, know your patient and at the same time look at your orders. And if it's questionable, you need to really clarify that with the provider. Signs and symptoms of circulatory overload. Shortness of breath. So again, remember, everything is connected. So if your circulation, if the heart has too much fluid, it has to go somewhere. So the next thing is it's going to start backing up to the patient's lungs, right? So you'll have respiratory symptoms like shortness of breath, coughing, engorged neck veins. And then so you have jugular vein distension and moist lung sounds. So you'll have crackles and you'll see some edema. So what are the treatments? Obviously, you have to stop that infusion. Make sure you're notifying the provider. And for the most part, they're going to order you to stop or slow down the infusion. And then next, usually, depending on your patient, they may order some diuretics. Very commonly ordered is your furosemide or Lasix. Again, it will depend on your patient, but that's a common thing that you will see in the clinical setting when a patient starts having circulatory overload. Next is extravasation. All right, from the term itself, right? Extra meaning outside, vasation, VAS or vas, is from the vasculature. So outside the vasculature. So this is happening when the infusion is really outside the vein or the vasculature. And so and usually this is caused by vesicant medication. So it's similar to an infiltrate, except it's a more severe version, and it's secondary to medications that are caustic or very vesicant. So they're vesicant solution, and this is when that solution goes in the surrounding areas, and it causes that tissue to break down. Signs and symptoms is going to be initially very similar to infiltration. So you'll have pain in the area, swelling in the area, maybe it can be pale, warm, and so on. But eventually what happens with extravasation is that it causes some tissue damage, tissue necrosis, and you can start seeing tissue sloughing in about 1 to 4 weeks depending on your patient. So as you can see here, right, a very severe form of infiltration is your extravasation, and usually again it's secondary to vesicant medications. And look at this piece of tissue basically out, right? You have this big lesion over here. So what do we do when a patient has some extravasation? So if extravasation is diagnosed, make sure you stop the infusion. Hopefully you don't have to wait until this happens, right? Make sure you're not waiting until you already have this, because at that point it's kind of late. I mean, you still want to disconnect it, but you want to avoid getting to this point. So stop the infusion, leave the needle in place or the catheter in place. Try to aspirate as much of the solution as possible, because again, if you want that solution out, because that's very irritating and damaging. It eats the surrounding tissue, so you don't want that there. So you want to try to aspirate as much as you could. You want to try to avoid manual pressure over the extravasated area. Why is that, right? If you're pushing on that very irritating fluid or substance, right, it can cause the tissue to absorb more of that and causing more damage. So you want to try to avoid putting pressure. Once you're done trying to aspirate, make sure you remove the cannula and then mark the area with the pen so you know the extension of the damage, because then you want to monitor, right, after some hours or maybe a day, is it expanding or is it even getting smaller, right? So that's why you want to mark it, notify the doctor or the provider, and if necessary, if you know what medication it is, right, you want to administer for the specific antidote. So there is a list of antidotes here if you want to check it out. Depending on what medication it is, it will tell you what interventions to do, like whether warm or cold compress, and also if there's any antidote, then it tells you also. So this is a pretty neat resource for that. And then make sure you're elevating the limb just to help with the swelling, the pain, and so on. And this is going to be very painful for the patient. As you can see, this looks very painful. Make sure you're administering pain medication as needed, as ordered, and always follow up and reassess to make sure that your interventions are working. And definitely collaborate with your physician. All right, we got some NCLEX questions. So, prevention of a local infection with an IV catheter is best obtained by doing what? A. Careful advancement of the catheter during IV insertion. B. Monitoring the IV site. C. Stabilizing the IV and avoiding areas of flexion. D. Maintaining strict asepsis. So, again, all these options may not sound really bad. They may all sound correct, but which one would be the best answer? And analyze your question, right? So what we're saying is we want to avoid infection. So what's the best way of avoiding infection? That would be maintaining strict asepsis. Next question. All right, you have a 75-year-old patient who was admitted with a UTI. He has IV fluids running at 125 ml an hour. The nurse notices that she seems to have trouble breathing. What is the first thing that the nurse needs to do? All right, before we even read the options, right, start thinking of all the things that we talked about. What does this sound like? Breathing problems, right? So what I want you to start thinking, oh, this patient, right, is the patient overloaded? Most likely, right? Anyway, so then knowing that, now you read your options, right? A. Call the MD. B. Stop IV. C. Raise head of the bed. D. Give furosemide to diurese the patient. E. Check her labs for acidosis. And again, just like the other question, sometimes your options sound really good. Everything sounds correct. But what is your priority at the moment? Right? Call the MD. I mean, you want to call the MD, but do you have to do it right away? Maybe soon, but not the first one that you want to consider, right? Because if you step out, what's going to happen? You're going to continue to infuse the fluid and the patient is going to get worse. So what you want to do first is really stop the IV. After you stop the IV, raise the head of the bed, right? Call the doctor, get that order for furosemide to hopefully give it as soon as possible. Check her labs for acidosis. That's really not a priority right now. And at this point, I don't think it's even appropriate for this type of patient because we kind of have an idea of what's going on. I will post the calculations portion of this slides on a separate recording.